Oh, wonderful. Thank you, everyone, for joining our updates in transplantation. My name is Leo Riella. I'm the medical director of the kidney transplant program in Mass General. I have the pleasure of sharing this session with Dr. Cotton, who is our clinical director of transplant infectious disease, Dr. Brian Keller, who is the medical director of the lung transplant program, and we may also have joining us one of the heart transplant providers as well very soon. So we put a really exciting kind of session here in terms of going over a few themes that we felt were really important for all our transplanted patients. So the agenda goes into what are the anti-rejection medications, why do we need them, and what should we watch for? We're going to go over some of the innovations that we are excited to share about transplant tolerance, which means like receiving an organ transplant without the need of long-term rejection medications. And we will then dive into some vaccine updates. And Dr. Cotton has some really exciting updates for us coming very fresh from the CDC and the FDA. So we're really excited about that. And we have Dr. Emily Bethea, who is the medical director of the liver transplant program, joining us as well. And we'll try to, of course, there are always differences across organs, and we'll try to address some of those as we go through the presentation. And please feel free, our amazing panel, to interrupt me at any point. But I'll start with just some general themes. So when we think about organ transplantation, when a body receives a foreign transplanted organ, being that a kidney, a liver, or a heart, there are certain things that come with that organ that may trigger the immune system to identify the organ, the foreign organ, or the transplanted organ as a foreign body. And if we think about it, it's almost like a fingerprint. So it's unique variations that come with that organ. And among all the things that are different between individuals, the HLA, which we call the human leukocyte antigens, are the proteins that are most polymorphic, most different across a donor and recipient pair. And when the immune system recognizes this foreign protein and the HLA primarily, it triggers the immune system, which is our army, to then go in and try to reject the transplanted organ because it sees as a foreign body. And it's very similar to how the immune system may see a virus or a bacteria. But unfortunately, in the case of transplant, it may cause harm. And the immune system have many different soldiers and generals that participate into that immune response. And the whole idea here is that we need the anti-rejection medications to weaken that immune system so you don't reject the transplanted organ. And there are a couple of different types of rejection that may occur. There's one rejection called a cellular rejection, which the cells going into the transplanted organ can cause injury. And there's also another type of rejection called antibody-mediated rejection, which is antibodies on the circulation that go in and targets the transplanted organ, leading to injury and inflammation. And the correlates of that is, on the antibody, it's almost like a guided missile that goes through the circulation until it kind of finds its target on the transplanted organ. The whole idea of using anti-rejection medications is to weaken that immune response and prevent a rejection process. And we have a number of combination of drugs that are important in order to prevent the rejection. And there are certain drugs that are used very early after the transplant because, early post-transplant, the risk of rejection seems to be the highest, in particular at the time of transplant. Those are called induction agents. We won't talk much about that, but we will talk about what we call the maintenance agents. So these are anti-rejection medications that our patients are going to take in the long term in order to prevent rejection. And then there are certain drugs that may be used in the setting of having a rejection, such as high doses of steroids, or in very specific situations, such as if somebody has an antibody-mediated rejection, a specific infection, and so forth. But we'll focus a lot on the maintenance agents or the anti-rejection meds that we use long-term. And one very important concept about, the amount of anti-rejection medications that a patient may need is that it really depends on what we call the immunological risk. This immunological risk is a spectrum that goes from a low risk up to a high risk. And there's certain characteristics of patients that may have a lower or a high risk. And I just wanted to highlight a few. So our immune system, similar to other parts of our body, do get age over time. So we know that older patients tend to have a weaker immune system than younger patients. So therefore, age is one factor that may may take into account when we're assessing this immunological risk. The second is if somebody's receiving either their first transplant or they had previous transplants. So the previous transplants usually put the patient at a higher risk category for having a rejection event. So they would vote here on the right side. Similarly, if they had a higher rejection event. And last of all, depending on the mismatch, depending on the differences in HLA that I told you, which is the foreign protein, almost the fingerprint, they're different across individuals. If you have a lower HLA mismatch, you fall into the lower risk category versus someone that is in the high risk category if they have greater incompatibility on the HLA with their donors. And all these things go into account in determining how much immune suppression a patient may need. But then there are other things that may also influence that, including their history of prior infections, as well as their history of prior cancers. So it's not a simple decision to decide on how much immune suppression or anti-rejection medications someone needs, but these are some general things that all our physicians, transplant physicians, are going to be looking for in order to help with some of these adjustments. So what are the combination of drugs that we use after transplantation for the maintenance phase to prevent the rejection? It usually is a combination of drugs. So I'll tell you that a majority of our patients are on a combination of tacrolimus, prednisone, and mycophenolate. And there are a few patients that may be on some other agents, such as mTOR inhibitors, sirolimus or everolimus, or on a drug called belatacept. And why do we use combination of drugs instead of using one drug only? The reason is that we want to try to use drugs that have different ways of weakening the immune system. This way, we are capable of suppressing, inhibiting the immune system in a maximum efficiency while minimizing lower the side effects of some of these medications. Maybe I will stop here and then ask some of my panel's colleagues about the different organs and how do they use this in their specific field.
Yeah, so in lung transplantation, we use those very same medications, prednisone, tacrolimus, and mycophenolate as our kind of a core maintenance immunosuppression, occasionally adding in an mTOR inhibitor. We do not currently use belatacept in lung transplantation.
And I'll echo both what Leo and Brian mentioned, that we use very, very similar meds in liver. Induction is usually somewhat different in liver if it's liver only. We also don't use belatacept, but those are probably the main meds we start with and then transition based on patient characteristics. Some of the mTORs we'll see used in certain patients who might have liver cancer. So sirolimus or everolimus are ones that you may see that favored for, but there's also varied data in that space. But these are the ones that we also use. Thanks, Leo.
I can follow as well, Leo, on the heart side. Similar to what you just heard on lung and liver, we use all the agents except for belatacept. Typically, we'll use sirolimus if there's evidence of coronary allograft vasculopathy or evidence of malignancy. But otherwise, these are their cornerstones as well.
Wonderful. Thank you. And this is Dr. Greg Lewis. So he's the medical director of the heart transplant program. And we also have Megan Doucette joining us. She's one of the nurse practitioners, also at the heart transplant program. Feel free to interrupt me again as we go through some of these concepts of anti-rejection medications. And the idea really here is is to try to shut off the engine of the immune cells. Similar to an engine, there are multiple things that are required for the immune cells to get activated. And when we're using this combination of drugs, we're trying to affect that engine at multiple steps and maximizing its efficacy and minimizing some of the side effects. And this is what this illustration kind of shows. Okay, now we're going to go over across some of the side effects of medications that I think are important to our patients and things that we're going to be asking them in the clinic. So tacrolimus. So tacrolimus we consider as being the kind of cornerstone of anti-rejection medications. It is one of the most efficacious medications to prevent rejection. But it does come with some side effects, and it requires drug monitoring on the blood. So these one of the drugs that we're going to be following in the long term by checking the blood and checking what's the level. And the reason we do this is that we want to avoid at all costs toxicity, as well as underdosing someone for that. If you have a very high level of tacrolimus, there are a few things that can happen. So patients may notice you have a much greater tremor, and they may also notice that their kidney function through a blood test doesn't look as good. And the reason why tacrolimus can affect the kidney function is that it can cause a tightening up of the blood vessels that go through the kidney filters, and therefore your creatinine can go up. And this is one of the things that we want to avoid at all costs. It can also cause some kidney damage in the long term, so we want to try to minimize extreme high levels of that, and that's the importance of some of the drug monitoring. And there are other things that we may see when tacrolimus are high, including a high potassium, including a low magnesium, and it may affect the blood pressure, hair loss, and increase the risk of diabetes. So unfortunately, it's one of those, necessary evils where we want to use this medication so effective that we cannot remove completely, but we do want to try to use it at a certain level where we can prevent the rejection, but minimize some of the other side effects that we may encounter. Any other comments about from my colleagues on tacrolimus, or things that we should mention about? I have one graph just showing what happens if you would continue monitoring the tacrolimus in the blood. We usually take it twice a day, and this is what happens with the levels. And the reason why we ask our patients to always, be very diligent about when they draw their blood in the morning in relation to what dose, the time that they took the dose the night before. And the reason this is important, because you can see what happens with the blood level of this medication. So if we miss by 4 hours, either earlier 4 hours or later 4 hours, the drug levels that we get could be uninterpretable. So it's really, really important for us to do that 12-hour trough levels, meaning if you took your medication at 8 p.m., we want to get your blood drawn at around 8 a.m. or so that we can have the best idea what this trough level is that allow us to then correct some of the dosages. I know there's some upcoming questions going on, and feel free to interrupt me if we're not addressing, or we'll type some of the answers as we go. And what's really frustrating, I think, for most of our patients is that even patients that have been taking it in a steady way, the tacrolimus dose, suddenly they may do a blood test and the level is completely off. And there's a lot of even interpatient variability, meaning two different patients may be taking, very different dosages, even though their blood levels are the same. Example, a patient may be taking tacrolimus 1 milligram twice a day, and another patient is taking 8 milligrams twice a day, and their blood level at the 12-hour is exactly the same. And so why is there such big differences? So there are multiple things that are very complex about tacrolimus, but there's some genetic changes, so uniqueness of everyone of how they metabolize the drug that varies, their impact of age, their impact of other drugs that can affect the levels. And this we have discussed a lot in the recent past because of Paxlovid, which is one of the medications that is used for COVID, that can significantly impact the metabolism, how this drug gets broken up in the body. And therefore, whenever we're using Paxlovid, there has to be a very tightly regulated approach on what we're going to do with the tacrolimus. And last of all, diarrhea. So diarrhea, you would think that you would have less of drug absorption, but unfortunately, because tacrolimus gets metabolized, get broken by the intestines, actually, when you have diarrhea, your levels in the blood go higher. So whenever someone has a diarrhea for a longer period of time, this is a situation where we want to get the blood test, because it's very possible that the tacrolimus level is going to start to rise and we need to adjust the dosages. So this is why, all these things together can impact the tacrolimus trough levels, and we may see variations even in patients that have been taking a very stable dose for a long period of time. What about mycophenolate mofetil, Cellcepto Myfortic? So this is a drug that's used in combination with tacrolimus. There's no need for monitoring the blood levels of this drug, but this drug does have some side effects that we always ask our patients when they come to clinic. They can cause diarrhea. So the GI side effect is one of the main ones, as well as sometimes upset stomach or a sensation of bloating. Sometimes they can also lower the white blood count, and we may need to adjust that. whenever we have an infection, this is the drug that we always, if they're high, we may consider reducing it just because of this effect on the white count, which can also is the white cells that fight us against infections. So this is something that we monitor very closely. And last of all is the prednisone. So prednisone also doesn't need any blood monitoring. We tend to minimize long-term the level or the dosages of these medications just because they do have side effects, in particularly higher doses. They can cause high blood sugar, high blood pressure, can weaken the bone, cause swelling and acne. The lowest dose that we use is usually 5 milligrams that we try to get in the kidney world very quickly to that level. Some of the, I'll stop here because there may be some variations in prednisone use across the organs, or maybe you'll get some additional input. Maybe I'll start, Dr. Lewis, anything that's unique on the heart world that we should share with our patients?
Yes, thank you, Jarell. I think this is a really nice overview of the different immunosuppressants. I think what we oftentimes find ourselves doing, just in terms of those of you that are on the webinar and say, that your combination may be different than other patients, is that we try to, balance the adverse effects that you've mentioned with the utility of these agents. And so, for one patient, they may come completely off of their steroids if they're experiencing some of the steroid-related side effects. But for another, they may be particularly sensitive to their tacrolimus, and as a result, they stay on prednisone, and then we end up running the tacrolimus levels lower. So I think that there is an individualized approach, with the ultimate goal being to successfully suppress the immune system sufficiently while minimizing the combination of side effects that you just reviewed.
Perfect. Dr. Keller?
Yeah, I would just echo that. I think it's really a balance, right, of protecting the organ with appropriate immunosuppression, but not over immunosuppressing to where you increase the risk for things such as cancer and infection. And for tacrolimus, we have a blood test that can measure levels very specifically. For some of the other medications, we don't, and so we use a lot of different factors to determine where each patient is at in terms of their level of immunosuppression. But unfortunately, we don't have the perfect test that says this patient's immunosuppression is exactly in the right range for their particular situation. So we have to take into account a lot of test results and other factors.
Mm-hmm. Wonderful. Dr. Bethea, would you like to add anything else from the liver world?
Yeah, I don't have much more to add. I will relay in the liver world, and in some ways we're fortunate. The liver is a large organ. It can kind of absorb a lot of antibodies, is one way we talk about it. And when it comes to rejection, there's a lower risk of rejection. So oftentimes, I know some people in the comments have noted, I'm this far out from my liver, I'm just on single agent. Sometimes we can move to that space, but there's other things. In particular, the reason that you need a transplant in the first place is your underlying liver condition autoimmune in nature. Does that require us to be on 2 agents long-term, or additional agents to prevent rejection or recurrence of the autoimmune disease? So all of that factors in, as well as other folks have mentioned.
Fantastic. Thank you. There are 2 other drugs that we briefly mentioned that they're not the most common drugs used, but they can be used as alternatives. So Tacrolimus, everolimus are part of the mTOR inhibitor family. They also require drug level monitoring in order to avoid toxicity. Unfortunately, 1 in every 4 patients do not tolerate this medication because of side effects. Here are a list of some of them, including, leakage of protein, the urine, mouth ulcers, and sometimes can affect wound healing. I think what's important is if someone is taking this medication, if they're going to go through any procedure, like a surgical procedure in particular, we do need to know that ahead of time, because we may change this drug to something else in order to avoid any problems with the wound healing. Some patients do extremely well with this medication. So unfortunately, it's something that it's hard to predict before we start, but that's definitely an alternative to some of the other drugs such as tacrolimus. Another of the drugs that it's mostly used in the kidney world is belatacept. So this is an infusion that happens on a monthly basis, usually using substitution of tacrolimus. It tends to be very well tolerated with much less side effects compared to some of the other drugs that we have. But it is not a drug that we use in patients that have not had a prior infection from a virus called Epstein-Barr virus. Okay, So it's only specific scenarios that we use it, and we'll be happy to discuss a little more offline about this drug. Okay, so from the anti-rejection meds, I think one of the things that we most see as problems after transplant is when, other medications are added to the regimen of a patient, and then we get into trouble. I think the general rule of thumb is that do not hesitate to contact the transplant team before initiating any new medication, okay? Including if it's over-the-counter or herbal medication, we want to hear about, because there are definitely potential interactions with the medications they're currently taking. So in the kidney world, our patients know this by heart, but anti-inflammatory agents and painkillers, so at least in the kidney world, we try to avoid as much as possible those what we call NSAIDs, which are ibuprofen, Motrin, Advil, Aleve. And the reason is that they can be associated with some kidney damage. I'll stop here and just get some insight from our other transplant programs, just to ensure that we give a message that can be useful across the organs.
We agree, Leo. I think sometimes in liver too, people shy away a lot from Tylenol, thinking that Tylenol may be damaging, but healthy livers can handle Tylenol no problem, and we much prefer it and ask to avoid the NSAIDs. So agree.
Same in lung, we avoid NSAIDs because of the effects on kidneys that you highlighted.
Same in heart
Same
for
here.
kidney and cardiac effects.
So the alternatives for some pain is Tylenol or acetaminophen. So this is what we tend to use the most. If there is an inflammatory condition that you may need to be treated with an anti-inflammatory, we tend to actually suggest a very short course of a higher doses of steroids, like 40, 30 milligrams for a few days. And our team would be happy to discuss whenever this happens in the future. All right. Drug-drug interactions. So there are plenty of drugs that can interact with anti-rejection medications. Maybe I'll even get Dr. Cotton here for a minute, because we know that there's a lot of agents used in the infection world that can interact with that. And maybe we'll get some insights of issues that you have seen in the past.
Yes, there can be some drug interactions, although fortunately there are not too many. You brought up Paxlovid, which does have a profound drug interaction. There are a few others that we don't use so commonly, things like fluconazole or rifampin. But I think those of us that manage transplant patients are really geared to think about drug interactions. We also have amazing support from our pharmacy colleagues, and there are a lot of online calculators and things that should be used. We do recommend that if you get a new drug prescribed to you, that you talk to the transplant team about it, because not everyone outside of our transplant program is aware of those drug interactions. So it's an important thing to be aware of.
Thank you, Dr. Cotton. So there are very few food restrictions that we provide to our patients, and really grapefruit is one that for patients taking Tacrolimus is something that we ask them not to take, because it actually affects the metabolism of Tacrolimus, and then star fruit is the second one. So only those two these main food restrictions that we have in general. There are other things that are important to know. There are some drugs that get affected, that can affect the absorption of mycophenolate, and that includes antacids and supplements such as magnesium, aluminum, calcium, and iron. So we tend to recommend our patients to try to not take them altogether. So if you separate for at least 2 hours the timing of these medications, it's enough to ensure that you're going to have a good absorption of those. Second, whenever mycophenolate is one of the most common drugs that we use post-transplantation, but it's really important to know that if a patient gets pregnant on this, it can be very harmful for the baby, okay? So if somebody is planning to get pregnant or became pregnant without knowing, it's really important to talk to our physicians as soon as possible, because we need to change. And for people that are maybe planning to get pregnant, we do have a plan of action in terms of changing medications in order for you not to take that medication mycophenolate during your pregnancy or just before you start planning that. And this can be done safely, but we need to plan a few months before this gets started. Proton pump inhibitors. So this is one of the most common drugs now used to reduce acid in the stomach. There's a couple of commercial names here that you may have heard. It helps kind of treat reflux, gastritis, as well as ulcers in the stomach. In the kidney world, we have seen a lot of problems of using proton pump inhibitors in the long term with an association with kidney disease. And we have also seen that sometimes it causes more of magnesium wasting. So some of our patients have low magnesium, and when they take this medication, it actually exacerbates, causes worsening of that. In the kidney world, we do have a protocol where for patients with a prior ulcer or with very clear indications of getting proton pump inhibitors or PPIs, they can continue that. For other patients, we try stopping it or using alternative agents such as Pepcid or famotidine. And this is really important. And I'll stop here because in the lung world, there might be some slightly different approach, and I want to make sure we voice that as well. Dr. Keller.
Yeah, so in the lung world, acid reflux has been associated with chronic rejection. And so we traditionally use proton pump inhibitors to reduce the amount of acid that's produced for that reason. That is obviously a balance between preventing chronic rejection as much as we can and the risks that Dr. Riella pointed out here with higher risks of kidney disease and other side effects. And so it is a balance, and we do monitor it closely. And in some cases, we may need to switch a patient off of a proton pump inhibitor to an alternative agent, but it is used very commonly in lung patients.
Wonderful. So maybe we'll move on to medication adherence after transplantation. This is one of the themes that I think it's so important for our patients that were already kind of transplanted. And the reason is that, you know, many of you may be taking multiple medications and frequent dosing, and they come with side effects, and life is busy, and sometimes, you know, you may forget to take meds, or they're expensive, the copay changes, and this happens and can really affect how compliant our patients are with their medication. So what it is important about it is that we know for sure that about 1 in every 4 patients may start missing pills frequently after transplantation. And why is this a problem is because if we look at what happens with the life of the transplanted kidney, and we see those graphs here that clearly show that patients that are not compliant with medication, okay, they tend to shorten the life of their transplanted organ significantly more. This is a reference to kidney, but there are evidence on the heart, lung, as well as liver, how important these medications are. And we know for sure that patients that stop taking their medications, they will reject their kidneys, for example. So unfortunately, there is a requirement of taking medications. There is the question of, okay, you know, I miss one day, you know, what should I do? So if you notice that you miss a dose and it was less than 6 hours then when you take the pill, just take the pill, okay? And then on the next time, just take the pill at the regular time. If it's more than 6 hours, we tend to advise patients to anticipate their subsequent dose. So take it earlier and then restart the clock then. And this is really important. So minimizing issues with the adherence of non-adherence is super important for the survival of this kidney. And clearly patients that miss medications, they do have a higher risk of developing what we call chronic rejection, which is a slow grade rejection, and ultimately can affect the life of the transplanted organ. Maybe I'll stop here, and you guys have maybe other suggestions about or issues with. Actually, I have some graph. Let me just show you one more graph, and then I'll ask your opinion. So this was really interesting. So there has been a few studies showing which day of the week majority of patients ended up missing pills, and it seems Friday and Saturday are the top 2 days of the week. So if this is happening with you, you have to recognize that this is a problem across our patients. So you have to be more vigilant on those days, okay? Because maybe your routine kind of changes, and this may be something you have to be more aware of. You know, at least after 2 years of transplant, rejection due to missing medications is one of the most common causes of somebody losing their transplanted organ. So this is really, really important for us to kind of highlight. And, there are a number of different strategies that patients kind of use in order to remember to take their meds, put an alarm, either on their phone or their watch. Others, have a pretty specified schedule and when they take, and they link when they take medications to other habits that they do frequently. So if they have breakfast, and they're going to go for the coffee, they put their medications next to the coffee and so forth. So it's really important to create some sort of habit that works for you to make sure that every time you're not forgetting to take the meds. There are great boxes out there that help you kind of organize your medications and ensuring that you take the right dose at the right time, and placing them in a visible locations. I want to also highlight, because when you travel, Dr. Cotton has some great advice about medications and what are some of the things you should do while traveling in order to prevent problems. Dr. Cotton, I'll love to get I know you give some great advice to your patients when they do the travel clinic.
Oh, yeah. Well, there are all kinds of tips, but it is really hard to not skip medicines, especially when you change time zones. We often recommend changing like by an hour to 2 hours if you're changing time zones dramatically. And then one of the biggest things is just whenever you travel, make sure you bring enough medicines. We've all heard about the plane cancellations and delays in travel. And really tragically, we're having a lot of environmental disasters now that will really slow down travel. So be prepared to be stuck somewhere for a while with your medications. I'm happy to talk a little more about travel during my section too.
Awesome. Thank you, Dr. Cotton. And last of all, cold medications. And I know the winter season is coming, unfortunately. And we always have questions, if you got a cold, what can you take and so forth. So as we spoke, Tylenol is safe, so you can definitely take that. We try to avoid the NSAIDs, including Advil, Aleve, ibuprofen, Motrin. Some of these combinations, flu combinations of drugs, they can sometimes, unfortunately, have medications inside that can raise your blood pressure. So we tend to avoid that. It is okay to take sometimes antihistamines in order to reduce the secretion. But the combo for flu and so forth, please check with your physicians before starting it, because some of those combinations may have medications that we do not advise for our patients. So please call the team, and we'll be happy to guide you through individual things. Okay. Maybe I'll stop here. For the anti-rejection meds and some of the discussions, could I ask my amazing panel to comment on anything else that we may have missed or that we should highlight here before we go to the next section?
I'd just like to amplify something that you said, which is that it can be challenging to remember or to understand every single drug interaction, but honestly, like that's what our teams are here for. So if you have questions about a missed medication or questions about how one drug may interact with another one, please feel free to call us. In terms of it doesn't have to be a medicine that's specific for the organ system that was taken care of with the transplant. It should be for all medications.
Thank you, Dr. Lewis.
I'll just reiterate agreement, Leo, with what you said in recommendations for the cold and the travel. So we'd be on the same page.
Wonderful. Anything that we should comment from the Q&As about this part that we should try to answer live versus some of the answers that have been going on, or something that has been recurrent that we should highlight?
I've seen a lot of questions, Leo, and I'd love to hear from the other organ systems about things with and without food. I think one thing we'll say, a lot of the questions open right now from the attendees are around medications and food administration and timing and spacing. I think it's safe to say there are a lot of nuances that may be patient specific and maybe even have to do with other medicines that they're on. Sometimes people are on medicines to help with GI discomfort or things like myelantia or antacids that do need to be spaced out or might have interactions with things like CellCept. And so for that reason, sometimes food things may come into play. But in general, you might hear variations if people are talking specifically here about TAC. TAC and MMF in food, meaning that sometimes it is recommended together and sometimes it's recommended that you could take it on an empty stomach. And so with other organ programs, I don't know if you have strict recommendations, but patients may have different things they hear from their providers here. I guess that's making it a little bit hard for us to respond to the questions because it might not be the same for everybody.
Yeah. I can say that, the consistency is one of the most important aspects about this. And, some patients cannot tolerate taking meds with their empty stomach, and that's completely fine. If every time that they take their meds, they're taking with food, when we do the blood test level for that drug level, we know, this is reflective of something that's happening every day. And I think that consistency is really important. We don't want you to, suddenly the day before you come to clinic, you take your pills on the empty stomach while the other days you're not. So I think that's one thing that at least we have tried to advise our patients to be consistent and to find ways that they can tolerate taking their meds and that works for them, because it really at the end we give you guys an organ transplant, but if it doesn't work in terms of all the side effects and it affects your quality of life, then we have to work together to improve that. Great. So maybe this is the second session is very brief, but it kind of goes over some of the innovations that have been ongoing at MGH in regards to transplant tolerance. And I'll briefly start, and then I'm going to pass to Dr. Nahel Elias, who just joined us. He's the surgical director of the kidney transplant program. So what is tolerance to start with, or transplant tolerance in particular? So this is, a state where there's a specific absence of destructive immune response against a transplanted organ without the use of anti-rejection medications, while your immune system is still capable of fighting other threats such as infection. So, and the benefits, in theory, the benefits of having a transplant tolerance is that you may have freedom from, a rejection event and the complications of immune suppressive drugs. And so we know, and we discussed multiple of these complications on the prior session, and these are just highlighting from the infection and cancer to some of the things that may affect blood pressure, diabetes, high cholesterol, tremor, as well as kidney toxicity. And the ultimate goal of, in theory, having transplant tolerance is that with less side effects, we could have one transplant organ for life. And what is exciting about it is that it has been a lot of development in the past 30 years in order to try to achieve what we call transplant tolerance. And the most protocols available out there, including the one at MGH, involves the combination of a bone marrow with the organ transplant. In our case, the majority of these transplant tolerance protocols have been done in the kidney world. So you do a bone marrow and a kidney transplant from the same donor, okay? And these are some of the examples of our protocol at MGH and some of the outside protocols that have small differences in terms of how they prepare the body to receive the bone marrow and the kidney, including just local irradiation, more lymphoid irradiation and total body radiation, and different combinations of some of these drugs. They all occur at the time of transplant. And the success rate is also variable and depends a lot on some of the differences between mismatch on the donor and recipient side. But, in general, it is a safe procedure to be done, but it is an experimental and a research. And I'm going to pass it on to Dr. Elias. He's going to talk a little bit about some of these differences across the different protocols, including, what's chimerism and also details of our current protocol.
Thank you, Leo, and thank you all for joining us. So chimerism is the state where there are essentially two different parts of two different bodies joining together within the person. So this is what we talk about as far as the bone marrow. So the bone marrow cells from the donor are existing in the recipient at the same time as the recipient own cells. And the reason we do this bone marrow transplant is to train the immune system to recognize the donor as part of this, what we call self. So our immune system is trained when we're babies to not reject our own organs, but it recognizes anything that and any specific organ that doesn't belong to us, and it fights it and it rejects it. So this is where, with chimerism, we're training the recipient body or immune system specifically to not reject the donor kidney. And our approach to this, which is as depicted in the bottom in the purple, is what we call transient chimerism. So there's a short period of time, usually a few weeks to a few months, where the donor bone marrow cells are existing, that we can see them within the blood of the recipient, but not beyond that. Other approaches have been arguing for mixed chimerism or high-level chimerism, as you see here, where there is significant amount of the donor cells. And the persistent high-level chimerism is something, for example, people who have bone marrow diseases or cancers that need a bone marrow transplant, they undergo that approach. This is something we're trying to avoid because we believe it does have, and it contributes to some of the risks of these other protocols. And our approach has been the transient chimerism. And essentially, we have the donor bone marrow cells existing in the recipient's body for a short period of time, but afterward, they disappear, and the entire cells that are visible and we can see them in the bloodstream are the recipient cells only. So they get their purpose, and this is where there is a conditioning regimen to get there, to get the bone marrow transplant, where we have to do some radiation and certain types of medication. It's a low-level chemotherapy, if you will, but it's very well tolerated, and we've been researching this for a long number of years. As Leo mentioned, we have a patient who's had 17 plus years of success with this. And for a short period after transplant, so after the bone marrow transplant, now the body has been trained, the immune system has been trained to now accept the donor cells as self and not reject them. So in the next 1 to 12 months after the bone marrow transplant, we start weaning the anti-rejection medication, the immunosuppression, and some patients are able to be successfully fully weaned, and they are no longer on immunosuppression, taking away some of the side effects of the immunosuppression and the risks associated with them. And part of these risks specific to the kidney is that these medication do have some harmful effect on the kidney, that we believe the kidney will last longer and potentially have that kidney last them for the remainder of their life.
And Dr. Elias, can you comment on the new clinical transplant tolerance center that was just created?
Yes, Leo. So we recently have established the Logoretta Center for Clinical Transplant Tolerance. This center is essentially the cumulative work of a lot of, it's led by Dr. Tatsuo Kawai, who's been here for over 25 years now. And he's done amazing work in the lab, researching this and doing a lot of work in getting this and getting it to the clinic, getting it to the patients who are able to tolerate it. And we've had a few patients over the years, but now we have the ability and the resources, hopefully, to be doing this on a more regular basis and with more frequent of these transplants, and finding the right patients who are finding the right patients who will do well with this, and identifying how we can treat them best. We're starting with the kidney, as we've been doing, but we're looking to expanding this into other organs. And there's a lot of ongoing research on that topic and other organ transplantation, being able to get to tolerance with them.
Thank you. Yeah, so there are a lot of preclinical studies in hearts, liver, and lung being done. But at least the clinical part, what's available right now is for the kidney transplant world solely, and we're really excited because this is the only transplant in the world, the first tolerance center in the world that has been created, and we can definitely talk more about that offline. And Stacy will send some of the references about the center. Maybe from now, I'll move these are some of the take-home points. I won't relate on that, and we'll pass it on to Dr. Cotton. They're going to give us, some really kind of fresh updates on vaccine. Do you want to share your own screen, Dr. Cotton?
Go. I need these slides, and then I'm going to pop in some hot slides. But for now,
Right.
slides. Great.
Sounds good.
Great. Okay, so actually, I'm going to skip this slide. And just to say, so we have new COVID vaccines out today, and I'll talk a little more about this, but this was some of the data showing that whether you had prior infection or just prior vaccination, the new vaccines, these are these monovalent XBB updated vaccines work really well. Okay, and these are not in immunocompromised patients, but we would anticipate that the new vaccines work similar to the old vaccines. Next slide, please. And then, yeah, I'll just pop my update slide in. So can you take those down, and then I will share, but I think it's this. Yeah, okay, great. Okay, so so what we talked a lot about today at the CDC meeting was that these COVID vaccines really decrease the risk of infection for the first few months. They definitely decrease the overall risk of severe illness for many, many months, and decrease the risk of long COVID. There are very, very low rates of serious vaccine side effects, and those are really vanishingly small compared with the benefits. I will say that many people say, oh, the vaccines haven't been well studied. Honestly, in my humble medical opinion, I don't know of anything that has ever been as well studied as COVID-19 vaccines. We are reviewing data for something that's been given to billions of people, billions of doses. It's really an astonishing amount of data. So, and if anyone's interested, you can watch CDC meetings and or look at the slides. They're all publicly available. Anyway, vaccine protection fades over time. So that's been one of sort of the disappointments, but that happens with many vaccines, that they just don't provide lifetime immunity. Measles vaccine does give lifetime immunity. Most of these vaccines in the modern era do not. Hopefully we'll get there, but so far we're not there. And a lot of people say, well, I had infection, I don't need a vaccine, but we definitely reviewed data today that having vaccination provides better protection, more robust protection than prior infection. And vaccines are cost effective, so good news. So these new vaccines, we just made this recommendation that they are recommended for everyone over the age of 6 months. There are a lot of questions. Right now, there are 2 mRNA vaccines, both Pfizer and Moderna, and those are going to be available within the next 48 hours. Supposedly. Novavax is another one. It's a different type of vaccine platform, and unfortunately that hasn't yet gotten FDA approval. Hopefully that will happen in the near future, and then Novavax might be available with this new XBB monovalent vaccine formulation. So this is what we just voted on within the hour, that these vaccines are recommended for everyone over the age of 6 months. And then I know what this audience is really going to be interested in is this slide that I copied. So for people who are moderately or severely immunocompromised, so moderately immunocompromised is most transplant patients. So it is recommended that you have your initial vaccine series, and then that you get at least 1 dose of the COVID-19 vaccine, and then you could get another dose. Now, what it says is they could be administered based on the clinical judgment of a healthcare provider and personal preferences and circumstances. It should be at least 2 months after the last COVID-19 vaccine dose. Now, what we think is that most likely these vaccines will be given probably every year. So I wouldn't run out and get 2 vaccines 2 months apart necessarily, with pretty rare exception. I would probably aim to get a vaccine every 6 months if I were a transplant patient. That way, if you get a vaccine this fall and then in the spring and then again next fall, that should provide good ongoing levels of coverage. Can you put the rest of the slides up for me, please? Whoever has those. Great. We do get a lot of questions about should we hold immunosuppression, that type of thing. But the bottom line is we've done some medical research and it has not been shown to be effective to hold immunosuppression, and it actually may be dangerous. So we don't recommend doing this in general. And this is likely not going to be the way of the future. So don't mess with your never mess with your immunosuppression. Next slide, please. Okay. So that's it on COVID vaccines. RSV is another vaccine that's new this summer. Next slide, please. So respiratory syncytial virus is a common virus that's sort of like influenza. It does account for, in children, up to 80,000 hospitalizations per year. And in people 65 and over or who are immunocompromised, it can account for somewhere close to up to 200,000 hospitalizations per year. And among people over the age of 65, it can account for 10 to 14,000 deaths. You can see on this slide, this is sort of the epidemiology of when we start seeing RSV. And basically every fall, we see RSV around the same times that we see influenza. You can see on that thick dark line where there's a peak in October, November last fall. You probably all remember that there was a bad RSV season last fall. We're already starting to see RSV in Florida and Georgia, so we may be off to another bad RSV season. So probably good to consider a vaccine for people 60 and over. Next slide, please. If you're really interested, you can follow all of these disease things online. RSVNet, InfluenzaNet, they all have live data that gets updated on a very regular basis. Next slide, please. And I guess hit forward. So there are two vaccines out there. Both are really quite effective, sort of in the 80 to 90% effective. They look to have a similar side effect profile. And so both vaccines are recommended equally. One is made by Pfizer, one is made by GSK. Next slide, please. And so right now, RSV vaccines are recommended for people who are 60 and over using either of the vaccines. It's sort of, right now, it's kind of a one and done vaccine. We don't have a recommendation for boosters. They are recommended in the context of using shared clinical decision-making, which means you should discuss it with a clinician. It could be a pharmacist, a doctor, a nurse practitioner, nurse, anybody giving you medical advice. Next slide, please. And I guess forward. Right, and here are the chronic conditions that you can, that would be recommended to get RSV vaccine. And I highlighted some in red because they may affect many people on this call, including immune compromise. So basically, and I don't think I said, but I'm actually part of the CDC vaccine panel, and I'm actually the chair of the RSV adult vaccine work group. So I've seen a lot of data, and I do believe that transplant patients 60 and over should receive this vaccine in order to protect themselves against another vaccine preventable infection. Next slide, please. So it is recommended that people get this optimally within the next, say, month or two before we start seeing an uptick of RSV. And so hopefully people can get that. It's readily available at commercial pharmacies. We don't actually stock it at Mass General yet. There's some intricacies about payment and reimbursement. So it's actually best to go to your local commercial pharmacy to get this RSV vaccine, and they do seem to be widely available. Next slide. Right, and if you want, you can get vaccines together. That's CDC guidance. I've been a little reluctant. I personally would rather spread vaccines out a bit, maybe get 2 at a time, but not maybe get a whole bunch at a time. I think that you may have a better side effect profile, and there's a theoretical possibility that you might have a better immune response. So next slide, please. The vaccines, so a couple of little caveats are, if you have Medicare and Part D coverage, it should be free. If you have private insurance, they have up to a year to cover vaccines. So you want to make sure if you're over the age of 60 and you register to get a vaccine, you want to make sure that it'll be covered. Otherwise, the prices are close to $300 each, plus about some type of administration fee that could be $50 or $100. So they could be expensive. So make sure you have coverage. And hopefully within the next year, they will become covered for everyone 60 and over. Next slide, please. And then just to highlight that there are, to avoid confusion, there's some maternal, so pregnant people vaccines, and then monoclonal antibodies that are being given to babies. Those are not for transplant patients at this point, unless they're a pregnant transplant person. But just so you avoid confusion, I'm talking mostly about the older adult program. Next slide, please. Great. I guess we go on to questions and answers.
Thank you, Dr. Cotton. I think there are a few questions that may be relevant to others. For patients that just got like a COVID vaccine recently, so the prior version, so should they wait or not, and when should they get the new one?
Yeah, that's a great question. So there's kind of a two-part there. I would say wait at least, probably wait at least 2 to 3 months to get a new vaccine. And so, kind of late fall, and then I'd get another one in the spring, and then another one next fall. Also, if you recently had infection, you could probably wait something like, we don't really know, but sort of maybe 2 or 3 months, and then get a booster. There won't be any harm. It's more about like spreading out your protection over time so that you don't kind of do everything all at once and then have some months where you have less optimal protection. So it's sort of evening the protection out over the course of the year. That's a great question.
And you may have mentioned, but is there a different COVID vaccines coming up, or is it Pfizer, Moderna, or?
So these are, the ones that we're talking about so they're all considered the same. It's the new monovalent vaccine. It's called the 2023-2024 COVID vaccine. They're all going to be the same. Actually, as of yesterday, when they had FDA approval, they actually canceled approval on the bivalent. So the bivalent will be pulled off the market, and this new vaccine will quickly become the only thing available. So if you just ask for a COVID vaccine, you will automatically get that new vaccine.
Mm-hmm. Perfect.
And yeah,
there was a question about Evusheld, which you want to tell us about what's Evusheld and what's happening since we last spoke.
Yeah, so Evusheld was a monoclonal antibody that we were giving to people to help provide additional protection against COVID. Unfortunately, this wily virus figured out how to escape through the protection of Evusheld, and it's no longer effective. And very sadly, it doesn't seem like the pharmaceutical companies in this era are developing any new monoclonal antibodies that I've heard of or that are likely to come to market soon. I think that with a lot of infection and a lot of vaccination, people are generally much better protected. It is sad. I think I would like to be able to offer transplant patients a monoclonal antibody, but so far I have not heard of anything coming soon down the pipeline.
Mm-hmm. There was a good question about RSV in lung transplant recipients, the vaccine. Is there a different recommendation there? Could younger patients also receive it?
So you can talk with your transplant clinician. Unfortunately, it's really unlikely to be covered by insurance for under the age of 60 because that's outside of the approval. You could potentially get it if you were willing to pay out of pocket for it, but it would be extremely unlikely to be covered by your insurance, which is sad. We are now reviewing data from the 50 to 59-year-old study group. And so hopefully within the next year, it will become available to people who are between 50 and 59. And then there are other studies that are ongoing. So the lower age limit may drop, or you can pay out of pocket for it. But that's obviously very expensive. Sorry, I wish I could do differently. I did actually put up a good fight about the cost, but I lost.
Thank you. Maybe some of our other panelists, any other questions that we should highlight live versus in the Q&A? Because I know we went over a little time, but we did start a little late, but I want to be cautious of everyone's dinner time and all that.
You know, Leo, I want to just say too, everyone should get a flu shot this fall. I know that all of us on the panel are all getting flu shots, right? Everybody, thumbs up for the flu shot, right? And everybody, all transplant patients, and then we strongly recommend all family members. In fact, the recommendation is for everyone in the US 6 months of age and older to get a flu shot. Today, we reviewed data on how many people have died without flu shots, and that's just really tragic. That's a lost opportunity.
Maybe we'll pass on to maybe some closing remarks from our panelists. Dr. Bethea?
Guess what I'll say is first, thanks to everyone for joining. Thanks to all of the colleagues on here for sort of spending the time and I think working in the space to try and help make a dynamic platform where we can have conversation. We can see by all the questions, sometimes we can't get to all of them, but it's really nice to be able to connect. I think when we started these now, over a year ago, we were in a very, actually, when we talk about almost a year and a half ago, a very different space and a lot of different kind of information coming out on COVID. So a big thanks to Dr. Cotton for everything she's sort of done. And also, I think hopefully what we feel is progress. We know it's still a challenging time. We know in the transplant space, the restrictions and things that sometimes make getting back to life a little more challenging, but we really hope that we're continuing to move in the right direction together and look forward to continuing to work with all of you.
Wonderful, thank you. Dr. Keller?
Yeah, I just want to thank, first of all, the patients for joining in today and asking such wonderful and insightful questions. I think hopefully this has been an educational opportunity for you to learn a little bit more. And I want to thank Dr. Riella, Dr. Elias, and Dr. Cotton for sharing the details on the slides that we presented. And, I think this can be overwhelming at times with the medications and the side effects and the talk of vaccines and how things continue to evolve. But I think to keep in mind and to focus, the goal with all of this is to hopefully keep you and your organ transplant as healthy as possible for as long as possible. And it does take some work, and we have to respond as things change around us in the world, such as with COVID and other things. But our goal here is to just provide you with the most up-to-date information to give you what you need to make the best decisions for yourself in collaboration with your transplant team. So I hope you find this informative, and it's always a pleasure to be able to interact directly with you as the patients in answering these questions. And thank you very much.
Thank you, Dr. Keller. From our heart team, Megan, you want to do some closing remarks from the heart transplant team?
Sure, Dr. Lewis had to step away. So thank you to everyone who's participated today, from the panelists to the patients. I think a big thing that came from today is that each patient is unique. Their medications, their medical history, their situation. So if you have questions, please don't hesitate to reach out to your care teams to get follow-up information from the discussions today. That's what we're here for. We're all usually very accessible. And if we don't have the answer right away, we'll look to our experts to get you the best information we can for your specific situation. So thank you to everyone.
No, that was perfect, Megan. There were a few questions that were very specific to individuals, and please reach out to your providers so they can provide the best guidance for you. Dr. Elias, any closing remarks, please?
I want to thank everyone again for joining, and thank you for a great panel that everyone would bringing these up. And again, I echo what was said. The questions is best discuss them with your own team. We have a great team in every clinic with the providers, nurses, nurse practitioners, physicians, as well as great pharmacy team, which is fantastic, helping you with a lot of the interaction discussion. And again, to emphasize the point about call us with any question you have, and we're glad to answer and take care of it.
Thank you so much for the entire panel. that participated, for our patients to being there, and in particular for Stacy for helping coordinate the webinar. Stacy, I'll let you finish with a few closing words for our whole team. Thank you.
Yes, thank you, Dr. Riella, and thank you to the panelists for always making time to do these. They're well received, and please continue to submit your questions, your suggestions for future topics. So we do see a couple of questions about this program. It has been recorded, and we always post our recordings on our YouTube channel. It takes about a week for us to publish it, so please be on the lookout for the email with the direct link. We'll also post on social media, so be sure to follow us there. And we'll also share the Q&A report, so you'll be able to see those specific questions that were asked and the answers. Of course, we'll remove any participant identifiers to make sure that your privacy is still at the forefront of our mind. So any questions, you guys know where to find me. You have my email, and we'll see you next time for our fall session or winter session.
Thank you, everyone.